To be honest with you, I was not a great advocate for myself when I first got sick. I mean, I was like a unicorn of the Hodgkins, nothing went how it was supposed to go. It wasn't good at all. It can be the difference between, having a good result or ending up, pretty much needing a transplant like I did. I truly believe that if I would have been a better advocate, that I might have not needed one.
Gut punch is a really great way to put it because it was. But I finished the 6 months of, ABVD that then went down to AVD. And gosh, I felt, despite a scan saying that I had no evidence of disease, I felt pretty awful. But something in my gut was telling me like, something isn't right yet.
Hi, everyone. I'm so happy to be here. My name is Chelsey Gomez. I am from Florida. I am just turned 33, and I have a daughter that will be turning 8 this year. I am a professional artist. I own my own cancer awareness brand named Oh You're So Tough. Yeah, so I was first diagnosed with Hodgkin's in 2018 when I was 28, and I was working a lot of hours. So I was very tired, just like Sam mentioned, but I didn't think much of it. I had weight loss I was trying, I was on Weight Watchers, but it never worked before, and then just suddenly started working. I had shortness of breath, and then at one point I almost crashed my car because I had a vertigo episode. So I ended up going to the doctor, and they told me it was just stress. And the only reason I got diagnosed with Hodgkin's was I eventually had a lump come up on the base of my neck on the left side. And I went to the urgent care, and then long story short, I had stage 2 Hodgkin's, and I also did ABVD. And about halfway through, we had to drop bleo because I had toxicity. And then I was re-diagnosed with Hodgkin's in 2019 as well.
I kind of wasn't feeling right. Like in hindsight, it's interesting to go back and piece things together, but I just sort of felt this vague sense of like, I'm tired. I don't have enough gas in my tank, but I was still running like 10 miles on the weekend, like long training runs, but kind of coughing a lot. So I was tired. But then I got a rock hard lump that just appeared above my collarbone. It was rapidly growing. It was painless, and it was rock hard. And I knew as a doctor, okay, I have cancer. And then once that came back with as Hodgkin's lymphoma, I kind of knew what the path ahead would be because right around the time when I was diagnosed in 2021, it was right before this big change that started happening with all this immunotherapy and stuff that Dr. Matasar is going to walk us through a little bit later. But it was just sort of the standard of what had been happening for a really long time, which is
so thank you for sharing, both of you. So Dr. Matasar, the treatment landscape in Hodgkin lymphoma has been changing quickly, to Sam's point earlier. Can you share more, again, high level, about the evolution that's been going on?
In terms of setting the stage for where Hodgkin lymphoma therapy is at now and how we got here, I would say that historically, like back in like the 80s, 90s, the 2000s, to do clinical trials to try to make Hodgkin lymphoma better was all about intensification. So we heard Dr. Siegel, we heard Sam talk about de-intensification. Back then, it was all about intensification. How can I ratchet the treatment up to make it even stronger, even more toxic, but even stronger against the lymphoma? And we were sort of climbing that mountain of pushing to see just how much chemo we should cram into someone's gullet in pursuit of a cure. Because all we had was chemo, so what you want to do was more. We've really come over the other side of the mountain now, and we're in a very different place as a discipline, lymphoma experts in the field. And we've moved away from intensification, and now we're into de-intensification, personalization, and leveraging treatments other than chemotherapy as we try to help both maximize the chances of cure and minimize the short and long-term risks of our treatment. And we've gone away from uniformly using this ABVD cocktail, which remains a very good treatment and a very commonly used treatment. And now we're using more often other adjunctive treatments like a medicine called brentuximab vedotin, or Adcetris as its trade name. We'll talk more about that this evening, in lieu of the bleomycin that you heard both Chelsey and Sam talk about potentially injuring their lungs, leading to cough or shortness of breath. So we're finding ways to cure more people and at the same time cause less harm along the way. And that's really where the future of Hodgkin lymphoma is going to take us. And we'll talk about that this evening as well, as we try to even make more progress on this mission towards more effective and less toxic treatment.
Yeah, I love that that's the trend and that we can continue going down that path. So we will be talking about, to your point, some of these newer promising treatments and a new direction. But first, can you give us a little bit more about that standard first-line treatment for Hodgkin lymphoma?
Sure. So when we as oncologists meet a patient for the first time diagnosed with Hodgkin lymphoma and we work through their treatment choices, it's important to understand that there are choices there. But we think through those choices together with our patients and their families, sort of splitting people into different categories as we understand the risk of their disease and the options that are presented because of that. And one first sort of way to bucket people, to try to put people into categories to help think through their choices together, is based on stage. And we talk about Hodgkin lymphoma early stage and Hodgkin lymphoma advanced stage. And people will often ask, what's my numerical stage? And stage 1, stage 2, stage 3, stage 4. We heard from Sam, I think that it was that sometimes it's not even clear to us as oncologists exactly what the stage is. Is it a stage 2E or is it a stage 4? So the staging exercise, which sometimes feels very black and white, can have shades of gray. But we do our best to try to put people into risk categories informed by their stage, and then think through the treatments that we know are best for that stage of illness. For early stage Hodgkin lymphoma, the standard of care remains, for the vast majority of people, ABVD. It's been around longer than I've been a doctor, and I used to have hair when I was using ABVD, so you know it's an oldie, but a goodie, and it still will cure the vast majority of patients. And sometimes we think about radiation therapy as part of that treatment, sometimes not. But ABVD for early stage Hodgkin lymphoma remains the standard of care. For advanced stage Hodgkin lymphoma, we've moved away from ABVD for most patients. And that's on the basis of really powerful clinical research that was conducted comparing ABVD to a program where the bleomycin was swapped out in lieu of this newer immunotherapy called brentuximab vedotin, which is a type of drug called an antibody drug conjugate. An antibody being a protein that binds onto the surface of a cell, and then stapled to that is a toxin. So this conglomerate thing attaches onto the Hodgkin cell absorbs it, and then the toxin is released inside the cell, kind of like a Trojan horse sneaking into the city and then releasing the soldiers inside. And it turned out that this newer program where bleomycin was swapped out for brentuximab, so BVAVD instead of ABVD, these initials are awful. It turns out that the newer treatment program not only got more people into remission and kept them in remission longer, but we now know that it actually leads to a higher cure rate and people living longer and everything good that we want to do as doctors for our patients. And because of this important research, we really now do use this brentuximab plus AVD program as our sort of traditional standard of care treatment for patients with advanced stage lymphoma in pursuit of cure.
Thank you for laying all that out. It's really interesting. You mentioned radiation therapy as well. And that has been its own sort of beast, if you will, in the conversations, a lot of considerations about when you're talking about long-term side effects and, where the mass is and you're radiating it. So what role do you think radiation therapy, what has it been playing? What role has it been playing? And what are your thoughts about whether it should still be used and in what situation?
It's a great question. And you're right, it is sort of its own beast. In the olden days, back even in like the 80s and early 90s, almost everybody with early stage Hodgkin lymphoma got radiation treatment as part of their care. And we knew then, and we know now, that it will cure a few more patients to use radiation therapy than not. But that slight improvement in cure rate never translated to people living longer because it's a trade-off. Yeah, we maybe do a little bit better with the Hodgkin lymphoma in some situations, but you're then paying a steep price, oftentimes in terms of long-term effects and late effects and risks of health problems later in life. And that can include anything from the radiation therapy putting patients at a higher risk for other cancers later in their life, particularly younger women who need radiation therapy to the chest. If that radiation touches the chest wall and touches breast tissue, particularly for women under the age of 35 or especially under 30, it really does heighten the risk of breast cancer later in life. Also, other stuff in your chest. Your heart is in there, it turns out, and the heart doesn't like radiation therapy much more than the rest of you. And we know that radiation therapy to the heart can lead to a higher risk of heart disease later in life. So there's all these consequences of the decisions that we make together in pursuit of our cure. And because we know so well about these late effects of radiation therapy, increasingly we try to be ultra choosy with who we use radiation therapy for. And we really restrict its use for what we think we really need it to get a cure. For many patients, for most patients even with Hodgkin lymphoma, we can cure them just fine without needing to use radiation therapy and without needing to put people at risk for health problems later in life because of that treatment. So we really restrict radiation therapy increasingly to use it if you need to. It's a great treatment. It can be life-saving when you need it, but don't use it willy-nilly.
Great. Thank you for providing that context and that color. So Chelsey, we're talking about side effects, short-term, long-term, late-term. You had mentioned in your introduction about the bleomycin, and you had experienced the toxicity, the side effects, and we've gotten lots of patient questions about it. And so with that the bleomycin, can you talk to us about what that reaction was and then what you did yourself about it?
Yeah, so after I think it was my 5th chemo, I think it was right before the new year, I remember it. I got the chemo like I had, 4 other times, but I went home and I spiked a really high fever all of a sudden. And, as a cancer patient, if it's like 100.4 or 3, you have to go. So mine was like 102, and my husband's like, we're getting in the car. And I was very lethargic and just not feeling well. So we ended up in the ER, and they told me I was septic. And so, of course, my mom heard that as well. Like, she was watching my daughter and just, freaking out because it's not good when you're septic. And they actually put me in the ICU. And I was in the ICU for at least 2 days. And the symptoms I had kind of dissipated after a few hours. I was feeling better, not 100%, but they started giving me antibiotics around the clock. And I had a feeling that it was something to do with the bleomycin, because I've researched what can happen with bleomycin because I have asthma, and that was something I had to consider going into the treatments. Everything I was seeing was adding up to it being toxicity, but there was nobody at that hospital who really treated cancer patients. Like, they came in and out, but they weren't there all the time. And it took about 4 days for my oncologist to actually come see me. And in that time, I pretty much diagnosed myself with bleomycin toxicity. I also stopped accepting the antibiotics because it wasn't an infection. It was a reaction to this drug, and ended up being that, yes, it was toxicity. It was confirmed later on. And I also had a pulmonary function test, and I think I had like a 30-point drop or something. And I am happy to report that I have regained a lot of my pulmonary function now, this many years out. So I know a lot of people, that's something scary when you do go through this. But yeah, and that, the doctor was speaking of, you need to advocate for yourself, especially when you're in a situation where your cancer probably better than the people that are there immediately. Like, it's not your regular care team. This was just a local hospital, and they had never seen this before. And so I had to speak up for myself, and it was hard, but I did it.
Chelsey, just to double click on that for a second. You said it was hard, and I think we've all experienced that as patients, where you want to advocate for yourself. You hear it from other people. It can be a little bit difficult to just speak up because you're like, well, I don't know, they're supposed to be they're leaving. So do you have any other tips, I guess, for people who are on the fence about it, who aren't sure if they're supposed to speak up?
Yeah, I mean, to be honest with you, I was not a great advocate for myself when I first got sick. I mean, the oncologist I ended up with was the one that was just walking by when I was in the ER initially, and I thought it was fate. It wasn't. He immediately upon meeting him in his office, he told me it was a good cancer, all sorts of things. In my case, I was like a unicorn of the Hodgkins, nothing went how it was supposed to go. It wasn't good at all. And sometimes I was quiet about it, or I didn't know what to do, because he was very I always looked things up, and he would call me Dr. Google, but not in a nice way. And so I was scared to bring up a lot of things. So I would tell you, if you are a young person and you are scared, or even a young woman, sometimes it's when you're a girl and you have a male doctor, sometimes it can be intimidating. Bring your family with you or somebody else you trust and have them speak up for you if you are scared to do it. I know a lot of people do that, and it's helpful because when you're inside of that room listening, your mind kind of goes fuzzy and you don't even know what's going on half the time. So it can be the difference between, having a good result or ending up, pretty much needing a transplant like I did. I truly believe that if I would have been a better advocate, that I might have not needed one.
Thank you for going into all that. And I completely can attest to the blanking out in the doctor's office and not hearing the same thing that like my family heard or whatever. So I appreciate that tip of, hey, bring people in if you can. Thank you, Chelsey. So Dr. Matasar, we'll talk about the specific trials, but can you explain first, what is the idea behind the combination drug approaches? And again, for whom would this benefit, hopefully?
So we've been talking so far, we talked about ABVD, we've talked about the progress that we've made beyond that with the swapping out of this brentuximab vedotin medicine instead of the old-fashioned bleomycin. This idea of immunotherapy has really been a revolution in a lot of different forms of cancer, but really nowhere has it been more impactful than in Hodgkin lymphoma, period, full stop, new paragraph. When we talk about immunotherapy in Hodgkin lymphoma, what we're generally speaking about is a class of medicines that have this nickname called checkpoint inhibitors, which is meaningless in and of itself, but I'll try to at least describe what these medicines do and how they do it. One of the ways that these Hodgkin cells that I described initially, these grains of sand, one of the ways that these cells survive in our body is that they are able to effectively shield themselves from our normal healthy immune system cells. And they put up these barricades and these ways of shielding themselves or hiding or preventing our immune system from doing the trash. Checkpoint inhibitors, and there's two of these that are approved for Hodgkin lymphoma, which are very similar medicines, truthfully, one called nivolumab and one called pembrolizumab. And again, these names are awful, so I'll call them Nivo and Pembro for short. These medicines are able to strip those shields, those barricades off of the Hodgkin lymphoma cells and allow your immune system to see what it was otherwise blind to. So when you're giving a patient a medicine like, the treatment itself does nothing to the cancer cell. It does not kill a single cell all by itself. What it does is it re-enables your own body's immune system to do the work for us. And it's a game changer. When we use these medicines just as a single medicine all by itself, not combined with chemo, not nothing, just all by its lonesome self, and use it as a treatment for a patient who's been failed by many different prior chemotherapies, brentuximab, all the other stuff that we traditionally do, they're able to put people into remission more than half the time all by themselves. And not just remission, but they're able to actually cure some patients. Cure means, despite chemotherapy having failed again and again and again, this medicine is able to eradicate the lymphoma, goes away, never comes back happily ever after the end. And that's amazingly powerful to be able to say, and it's an amazingly powerful treatment modality for patients with Hodgkin lymphoma. So that's where immunotherapy sort of started in Hodgkin lymphoma. And the more we learn about how good these medicines work, the more we want to use them for more patients to try to help cure more people. So it went from being a last-ditch effort after everything else has failed to being part of the treatment when it comes back after treatments like ABVD, and using it in that situation was able to help more patients. And now we're seeing the initial results of our first trials of using it as part of first treatment. So instead of ABVD or brentuximab plus AVD, we're now starting to see first results come out from incorporating these in combination with chemotherapy like AVD, but instead of combining that with bleo or with brentuximab, now we're combining it with Nivo or Pembro, these newer checkpoint inhibitors, and starting to see early results that are very promising.
Great, wonderful. Thank you for that. Really quickly, before we shift into the relapse refractory part of our discussion, any idea of when we could see the FDA approval of this sort of movement to the checkpoint inhibitors in frontline?
Certainly not anytime super soon. The first results that we had were read out at major conferences over these last months. This is still very early data. And listen, when it comes to Hodgkin lymphoma, us doctors were very conservative. We don't want to mess this up because we know that the stakes are high and we know that many people will be cured with traditional treatments. So we don't want to change gears until we're really confident that we're not hurting people in the process, right? So the initial safety readout of this combination using the checkpoint inhibitors in first treatment looked, I would say, better than any of us expected. A lot less of the immune-related side effects that we're accustomed to seeing when using these immunotherapies. And they do have their own immune-related side effects. There's no free lunch. So we want to see those data mature, as we say. We want to see how people do over time and make sure that there's no safety signals, no dangerous signals about increased late effects or late side effects happening as we gain more experience with this treatment approach.
Great.
Long story short, we don't want to change any time immediately soon. And we're probably looking a couple of years down.
Okay, that's good to know. Dr. Matasar, let's talk about the treatments that have been standard of care for relapse refractory Hodgkin lymphoma patients, and how is it changing?
So again, you're going to hear themes from me this evening, right? Which is that we've moved away from chemo to trying to use newer medicines. So historically, when chemo failed, how about some more chemo? And we would use these other chemotherapy programs that use different chemotherapy medicines than the first cocktail. And the most commonly used in America historically was a program called ICE. So it's ICE, different than ABVD because they're different medicines, but still chemo. We've really moved away from ICE being the standard of care, or certainly not the only standard of care, and we're using more of those other medicines, brentuximab, the checkpoint inhibitors. You can use one of them all by itself. You can use them in combination. It's informed, of course, by what we did the first time. So if patients get brentuximab as part of their first treatment, we're not going to rush into doing it a second time, and we'll probably want to do something a little different. So maybe we would use checkpoint inhibitors there alone, or combined with some milder chemotherapy programs. This is sort of the art of medicine, right? Trying to pick amongst a number of very effective choices, chemotherapy, brentuximab, checkpoint inhibitors, and how do we leverage those medicines and how do we combine them to achieve our patients' goals, always with this view of maximizing the good and minimizing the bad.
Wonderful. Thank you so much, Dr. Matasar. Sam, I want to go to you because, in your story, in your experience, you relapsed just a month after finishing your first line treatment. Can't even imagine what a gut punch that was to go through all that and then find out that news. Can you just give a quick summary of, what was that conversation like about where you were going to go next?
Yeah, absolutely. And gut punch is a really great way to put it because it was. But I finished the 6 months of, ABVD that then went down to AVD. And gosh, I felt, despite a scan saying that I had no evidence of disease, I felt pretty awful. And at that point, I wasn't sure, am I just feeling awful because this is just what a body feels like after you've had 6 months of this poison? I'm not sure. But something in my gut was telling me something isn't right yet. But my scan was clean. So just kind of focused on recovery for a little bit. And then within a month, I really started having symptoms that were eerily reminiscent of my initial symptoms. So just a wheeze only in the left upper part of my chest and a little pea-sized lump. And so that time around, I was like, okay, I think I'm pretty clear what's happening here. Got a scan, led to some biopsies and a diagnosis of a relapse. And the whole while I'm preparing myself oh my gosh, I'm going to have to go through ICE. I'm already researching on Google, the next, treatment regimen that I'm going to have to go through. And I'm thinking for sure I'm going to have to go through something called ICE or DHAP or one of these other regimens that have been used longer term for relapse refractory Hodgkin's or salvage therapy. And so then when the relapse was confirmed and my doctor said, there's this drug now, it's this targeted therapy called brentuximab, and we're going to try, would you be open to trying that alone for a couple months and then repeating a PET scan to see where we're at, instead of just doing the ice. And the kind of decision making there was that there was a pretty decent chance that if the brentuximab didn't work to get me into remission before transplant, that I would then have to go on to get ice, multi-drug, kind of more traditional chemo. But that was a chance I was willing to take at the time because I felt so beaten up by having to get, all those months of traditional cytotoxic chemotherapy and just all the side effects. And so that decision made sense to me in my life at that time. Whereas maybe other people may have been, no, I want to hit it hard and do that right away. For me, I was like, I'm going to take the least amount of poison possible to get me into remission before transplant. And it worked. I got a strong remission before my transplant. And then I went on to get the bone marrow transplant. And I took brentuximab. I just finished 2 months ago for almost a year of post-transplant consolidation treatment. So yeah. But it was like, for me, it was like real time because even 6 months, a year before, had that exact same clinical scenario happened, based on the science, that may not have been an option. But because those studies were just coming through and the data, my doctor said, this is kind of becoming a thing now based on the research. And it seems like it might really fit you based on how, bad you're feeling. And so that was perfect for me. I was so grateful.
Yeah, no, and I appreciate that. And it just that the timing matters, right? To your point, it just had happened. You had also mentioned in terms of like the reactions or side effects, you worked with your doctor to manage them. Can you share anything that was helpful there?
Yeah, I mean, I have a lot of side effects. I had a lot of nausea, vomiting, and yet like paradoxically gained a ton of weight during AVD from all the steroids, just kind of blew up. And was developing a lot of problems from that. Glucose, liver enzymes were increasing, inflammation in various organs. And I think actually in hindsight, that was also making neuropathy really bad at the time, because once my glucose got better and I lost the weight, my pain and my nerves got better too, despite the fact that I was getting more medicine that theoretically should have been impacting the nerves. So all the systems can kind of have an impact, and taking care of the whole body can be really important. And so, yeah, I talked to my doctor about diet, lifestyle, and supportive therapy, and what are some complementary therapies that I could try while I'm getting my traditional medicines to support my mitigating that. And I also took a lot of medicine at the time. I needed pain medicine. I needed nausea medicine. I needed all the tools in the toolbox to cope with living day to day, because it was just really hard. And I had a lot of the medicines for me cause a lot of mood and neuropsychiatric side effects. So I had problems thinking. I had problems at some points like driving or following a list of simple items. And that was really tough for me. That was a really far fall in terms of functioning, going from doctor to like, now I'm having trouble shopping a grocery list of 5 items. And so that was pretty devastating. So when I found out that I could do brentuximab as therapy leading up to transplant, that gave me huge quality of life back, because as those other drugs cleared out and my body healed, I could think again, and I started feeling myself in here again, and like, I'm not gone, I'm still there. And that mattered so much to me. It was a huge gift.
Please explain transplant. Dr. Matasar, again, that challenge of less jargon. Can you explain the transplant in this context?
So the first thing to say is that there's 2 types of transplant. And what we're talking about so far is a treatment that is, the full name of which is called autologous, or from yourself stem cell transplant. And to call it a transplant is actually wrong. There's no transplantation going on. It's just a word that we use. What this treatment is that you're hearing from Chelsey and Sam is basically just a trick. And it's a way of letting us give a round of super strong treatment. When you give a regular strength treatment like ABVD or the ice that you heard mentioned, we give those treatments and then you let people recover. Sometimes if the chemo's stronger, you might need to give a little bit of medicine to boost the recovery along. Here, we're talking about a treatment, a single course of treatment, usually 6 days, that is so strong that if I just gave it to my patient and gave them a hug and said, I'll see you later, I wouldn't see you later. It's too strong. And we need a very powerful antidote for such powerful treatment. And the antidote that we use is actually a person's own stem cells, these special Adam and Eve progenitor cells that live in our bodies and let us heal. And a process is undertaken where we actually filter the blood ahead of time with a process like a little mini dialysis, where we filter out a few of those special stem cells. We put them in the freezer next to the chicken parm, and then we give people the 6 days of chemotherapy, and then we thaw out those cells and give them back as an antidote. That course of the 6 days of treatment, and then the stem cell reinfusion as a little mini transfusion as the antidote, that program is what we here are calling a transplant. That's different than an allogeneic or donor stem cell transplant, where there really is transplantation going on, where your immune system is being put to sleep and a new immune system from a sibling or a stranger is being put into your body to give you a new immune system. And then we task that new immune system with attacking your cancer for us. That's a very different ball of yarn and really not what we've been talking about this evening.
Are there other options aside from chemo to get into remission before stem cell transplant? And, Sam did give an example of what she went through instead of going into that very harsh ice, regimen, which now we can actually go to Chelsey about with your experience, because you also got a transplant.
So I relapsed in 2019. It was a later part of 2019, and I switched over to Mayo Clinic in Jacksonville, Florida for my care. And I had been researching, through the Relapse Refractory Hodgkin's groups out there on Facebook. I saw that there was nivolumab, brentuximab, all of those things, and they were a lot less harsh. So I asked about it when I went there, and it was kind of a newer thing at that time. And my oncologist said, yeah, we can give it a try. It's had really good results. And, like Sam spoke to, the side effects for ice and the side effects for brentuximab is a night and day difference. So I don't think like anybody wouldn't try the less harsh one leading up to transplant. So I did. And I had 3 of those treatments, had a scan, and my cancer progressed. And my oncologist was honestly shocked as well that it didn't respond whatsoever. And that made me actually ineligible for maintenance, like what Sam had. I'm not eligible for that. I didn't get any. But so we switched to ice, and ice was the first chemo where I had to be inpatient. I was inpatient for 3 days every time, and it was intense. Like when your hair falls out on ABVD, for the most part, it's like slowly coming out. Well, with ice, pretty much 2 weeks to the time I had it was like just clumps of hair coming out, and I was very sick. It was very, very harsh chemo. And I think just really having open discussions with your oncologist, like if you do find other studies or other treatments, they should be open to answering your questions about it and not being dismissive, even if it's not an option for you. They should be able to explain to you why or why not. And definitely if you are a young person about to face a transplant, make sure that, or even if you're not, but if you're in childbearing age, please ask about fertility, because I am now in menopause at 33 years old. It was explained to me, I understood, and we didn't really have time to waste to get me to the transplant, but that's a conversation you should bring up not only when you're going into a transplant, but when you first get diagnosed with cancer.
Thank you, Chelsey. Yeah, those are very important questions. So Dr. Matasar, for relapse refractory patients, can you summarize sort of this combination of chemo and immunotherapy, and in the context of a transplant, hopefully what this might lead to?
The goal up until now has always been for patients who have their disease come back despite good first treatment is to get their disease into remission, meaning make their disease disappear on our scans and have a PET scan look normal, and then to take them into this round of high dose therapy, this auto transplant, in an attempt to maximize the chances of cure. We're now starting to see our first forays into, can we cure people reliably and consistently without a transplant by leveraging these immunotherapies, either alone or in combination with chemotherapy? This remains a clinical trial type question. This is not a DIY thing, but this is my hope for the future, is that we'll be able to use these treatments, particularly immunotherapies, to really limit our need to take people through the rigors of high dose chemotherapy, cure more people, and cause fewer problems and symptoms.
What happens, I guess, if these studies are happening And it's limited to what's approved, and if you can get into a clinical trial. But let's just say that it's on the table. If the ABVD doesn't work, that there's a relapse refractory situation, maybe there's some radiation that's been involved, some other things. And then you have these studies about, oh, well, brentuximab or nivolumab or pembro, maybe alone or in combination. Like, how are doctors having that conversation about what is the right thing to do next, or what is the most promising course of option next?
Yeah, it's really hard, right? This is the art, standing next to the science. And my art is not Chelsea's art, but there is some artistry to what we try to do, and it's to try to figure out the right lid for each pot, and how do you help a patient navigate their course of their illness. There is no one size fits all anymore. It used to be ice baby, like it's all we did, and it worked good, and it was awful. But now we have a range of choices, and you have to sit with a patient and think through, how much disease is there that I'm trying to shrink away? How quickly is it growing? How do you feel? How sick is it making you? How quick do we need to get you better? What was your first treatment? How well did it work? How badly did it not work? And take all of these factors and try to cram it into your doctorly, brain, and try to spit out some reasonable recommendations. Sometimes you're going to be as gentle as brentuximab all by itself. Sometimes you'll want to give more chemo. Sometimes you'll want to give checkpoint inhibitors alone or with BV. Sometimes you want to do checkpoint inhibitors plus chemo. These are all reasonable courses. Ideally, what you're doing as a doctor is working with your patient as a person, as an individual, and charting a course that makes sense for them, for their illness, and for their life.
Yeah, it's a really thoughtful response. And I think, are some of the considerations, I heard you say it's the treatments you had before, how successful they were, what's already been done. What about things like age or comorbidities or those kinds of factors?
Absolutely. And, we try not to be ageist, but truthfully, taking care of a 30-year-old is different than taking care of a 90-year-old. And to not recognize that would be silly. That being said, it's always a matter of individualization, understanding an individual person's goals, their preferences, what risks they're willing to take, what matters to them, and then try to figure out the best treatment for that person, given everything you know about them, about their value system, and about their goals of care. And I was really disheartened, Chelsea, to hear your story of your doctor disparagingly calling you Dr. Google. Nobody should have to deal with this stuff anymore. We've got to be better than that.
I'm like, thank goodness I was, because if I wasn't, I would.
No shit, right?
Exactly.
Number one is everybody should feel empowered to come into a conversation with a doctor as an equal partner in this process. I tell my patients, this is about you. It's not about me. I got no ego in this. And this is your mountain you're climbing. I'm not climbing the mountain. I'm the Sherpa. I'm dragging your bags alongside you, but this is your climb. And I'm here to help. So if you as patients, as caregivers, aren't feeling valued and heard, then you may not have found a right fit for you in terms of your care team. Everybody should always feel free to be getting a second opinion. And I think that not enough people take advantage of this sometimes. They don't want to insult their doctor. I don't want to be that guy or that gal, and I don't want to be a pain in the ass. Be a pain in the ass. I like nothing more than when my patients are pains in the ass and they come with me with lots of questions. It means they're doing their homework and they're really invested and they want to learn and they want to take advantage of whatever I've got up in my brain. I love nothing more, and any doctor should love nothing more than a patient who's all in on partnering with me on making this thing work. So be vocal, do your research if you want to. You don't have to, you shouldn't have to, but if you want to, and if it's something that you value, then that should be celebrated by your care team and never put down.
I think that a couple of key things that I've learned are having lots of questions doesn't make you anxious. So it's okay to have lots of questions and concerns and to look things up. That doesn't mean that you're an anxious person. And I think it's okay to really reject that label because I think it means that you're just appropriately concerned about your life and the quality of your life. As the patients, it's up to us to tell our doctors what's really important to us. Running's really important to me. Playing guitar is really important to me. I love painting. All the things that we like doing. Share with your doctor what's really important to you. Not only will I think it help them kind of just enjoy their day a little bit more, to know you as a human being, but it will really help to inform the treatment decisions. And I think that there were times in my treatment and stories that I've heard from other patients in groups where it felt like to want anything more than not dying, I felt like I was made to feel like it was greedy to just want more than just not dying as a cancer patient. But I think we're beyond that now in medicine. I think we are in the era of personalization, of community, of individualized kind of care within the guidelines of all the new things that are being discovered. And it's not greedy to want to keep exercising to some degree or keep doing your art or whatever defines quality of life for you. So yeah, it's tell your doctor what's important to you, reject the anxiety label, and my whole slogan that I'm trying to get going is let's shift the focus from mortality to vitality in cancer. I think vitality in cancer is huge, and it's so much more than just not dying. It's the living part.